Dr. SRISHTI, postgraduate in pediatrics from Pandit JNM, Raipur. I also welcome Dr. Kaushik Kishore, senior pediatrician, Dr. Ashok sir, Dr. Mala, and all others. So, without wasting much time, I request Dr. SRISHTI Trivedi. So please go ahead with your case presentation.
Good evening, everyone. I'll be presenting case of Deepak Kumar Sahu, 5-year male child, Hindu by caste, who was admitted to the Department of Pediatrics in the pediatric ICU unit. He was a resident of Patan, Durg. The informant of this case is the mother of the patient, who is a reliable informant. The child came with us with complaints of fever since 12 days, cough since 7 days, difficulty in breathing since 5 days, and chest pain since 3 days. History of presenting illness. The patient was apparently all right 12 days back when he developed fever, which was high grade, sudden in onset, remittent type, progressive in nature, and partially responsive to medications. The child was not very playful in between the episodes, and it was not associated with chills and rigors, ear pain, running nose, any rash, burning micturition, or joint pain. Fever was followed by cough 7 days back, which was acute in onset, continuous, not relieved by medication. It was non-productive in nature, which was aggravated in supine position. There was no diagonal variation associated with cough and no associated hoarseness of voice or association with meals. This was followed by difficulty in breathing 5 days back, which was more in supine position. Initially, the child preferred to sleep in the left lateral position, and there was no other seasonal variation present. Difficulty in breathing was followed by chest pain 3 days back, which was sharp and aggravated on coughing, and was more on the left side of the chest. There was no history of bluish discoloration of skin, joint pain, or similar episodes in past. Past history, there is a history of varicella infection 1 month back, which resolved spontaneously with symptomatic treatment. No history of drug intake or transfusion reactions. Birth history, antenatal history, the first trimester, it was a booked pregnancy. The mother was immunized with regular follow-up. There was no history of fever, rashes, or any drug or radiation exposure in the first trimester. The second trimester was uneventful. Quickening was felt at adequate time. The fetal movements were then perceived throughout the pregnancy. And in third trimester, there was no history of any infectious causes or antepartum hemorrhage. Natal history, it was an institutional delivery. Delivery was in the community health center of Durg, conducted by the staff nurse. It was a term gestational. The baby's weight was 2.8 kg, who cried immediately after birth, and there was no history of any NICU admission. The feeding was initiated 2 hours after the birth. Development history, the child is developmentally appropriate for 8, with DQ being 88%. Nutritional history, the pre-illness nutritional history was calculated as the information given by the mother. The child is non-vegetarian. They prefer to eat non-vegetarian meals about once a week, and egg is eaten 2 times a week. During in the pre-illness, the calorie deficit was around 17% and the protein deficit was 25%. And during the illness, the average calorie intake decreased to the deficit of 38% and protein deficit was present about 50%. Immunization history. The child was immunized as per the national immunization schedule with appropriate immunization taken. Family history, first born to the non-consanguineous marriage in a 4-membered family and no history of any respiratory disorders in the family. Socioeconomic and environment history, lives in a kacha house with 2-room kitchen with a separate toilet, gets corporation water for drinking and cooking, close sanitation is present, father is a farmer, studied till 6th class, not a stable income source, and mother is housewife.
Wait. Don't go to the general exams.
Yes, sir.
Very nice, very good history from SRISHTI Trivedi. Very good history. Thank you very much for starting off very well. You please go back to your first slide. We'll analyze the history.
Yes, sir.
In detail. Okay.
Yes.
Now, actually, there are 4 symptoms. This is a 5-year-old male child who has had 4 significant symptoms.
Yes, sir.
That is fever for 12 days, cough for 7 days, and difficulty in breathing for 5 days, and chest pain for 3 days. 4 symptoms are there.
Yes, sir.
Very right. And you first analyze the first symptom, that is the fever. Can you go to the next slide?
Yes, sir.
Now I'm going to ask you one by one your points related to fever, and I'm
Yes,
going to
sir.
ask you to interpret that.
Yes, sir. Sir, the child was apparently all right around.
Just wait. You make a statement that the child was apparently all right 12 days back. What do you mean by apparently all right?
Sir, there was no history of any other prodromal infection or any other causative factor before 12 days. And 12 days is a definite time that is perceived by the parents. It might be.
Okay, fine. That's a very good statement you made. Apparently, all right. I want to ask you why you are starting with a statement like that. Apparently, all right. What is the reason?
Sir, they have stated that it was a high-grade fever. Any infection when first comes to the body and then it localizes, it does not progresses as sudden. It was perceived about 12 days back. It might be the presentation that child was experiencing some kind of malaise or decreased in activity that was not noticed by the parents. We were told that around 12 days back we have noticed that the child has developed high fever, and it was high grade. According to the parents, they have not even measured the temperature. They were just initially they were telling we just touched the child and it was very high grade, but after that they went to their local dispensary and got it checked, and when they got it checked, that it was a documented fever. And after that there was proper documentation of fever done in the local dispensary only, and then it got checked.
No, Dr. Srishti, I understand what you're saying. Very logical answer you're giving.
Yes,
I want you to explain to me what is the meaning of the statement saying that the patient was apparently all right. What do you mean by that? What are you trying to tell me? What should I infer from that statement from you? That's what is my question to you.
Sir, it can make an inference that this is the information that is given to the parents by us.
No, parents are giving. See, what is your interpretation? Parents' job is to give the information. Your job is to interpret the information. What is your interpretation? Can anybody put in the chat box why I am asking this question? Srishti?
Sir.
Okay, I'll tell you.
Yes.
Tell you the reason why I'm driving home a very important point.
Yes.
In any history, you have to decide when the illness started.
Yes, sir.
When the illness started, and the period at which the illness, whether it is acute illness or recurrent illness or chronic illness, when did it start, that information can be obtained from the history only on detailed questioning about the entire well-being of the given child. That is what I was trying to drive home. In fact, I'm very fond of telling students, you know, the so-called apparently all right is not probably a right statement. You must substantiate it by saying whether the previous day the child is going to school,
yes,
and you are apparently all right.
Yes, sir.
Wait, just wait. You are apparently all right should be very clear. For example, you know, WHO defines good health, normal health in children, not as simply absence of disease. You know, mental, physical, everything should be perfect.
Yes.
So you could have mentioned very clearly this child who was well as per history till the fever started. is going to school, has been developing normally and growing normally. You could have made one sentence there indicating to the examiner everything was all right. This is only an acute illness. That is what I was trying to drive home. So the message that I have for all the personages listening is that you should ascertain the time of onset of whatever illness that you are talking about. And that can be done from the history very well by asking leading questions and saying everything was fine. I wanted to know from you, was everything absolutely fine or were there problems before?
Yes, sir.
Were there problems before or everything was fine?
No, sir. Child was, according to the mother, child was playing till afternoon of that day.
Yeah, playing, going to school, all that.
Yes, sir.
Yeah, okay. That is point number one. The
Yes.
second is, you have mentioned remittent fever. What is remittent fever?
Sir,
Just
it was.
wait. Don't be in a
Yes.
hurry. I'm a bit slow. Don't worry, Srishti. I'm extremely slow. Remittent. What is the meaning of remittent?
Sir, remittent is a type.
One minute. Just wait. Second statement. I want you to explain three adjectives you have put.
Yes, sir.
One is remittent type fever.
Yes.
Second is progressive in nature. Third is partially responsive to medication. All the three statements I want you to clarify to me what you meant.
Yes. Sir, remittent is a type of fever in which the fever, the normal temperature, that is of 98.6 degree Fahrenheit, and for fever we take it as 100.4 degree Fahrenheit. In remittent type of fever, the fever never touches the baseline, and the difference is more than around 1 degree Celsius when the medication is taken or the type of fever is concerned. There was a record of.
Did the parents have a temperature chart for you to come to?
Yes, sir. They told there was a in the referral paper. There were 2 referral papers present, and in the referral paper, temperature charting was one of the temperature charting. It was mentioned on examination also, and continuous fever it was written. And I asked the mother specifically.
What's the significance of remittent fever versus continuous fever?
Sir, in continuous fever, it is a type of fever which never touches the baseline. Also, that in continuous fever, the difference is more than around 1 degree Celsius.
What is the etiology of remittent fever?
Sir, infective causes such as pneumonia or UTI, and any septic foci is present.
Even in enteric fever, you can
Yes,
get. Agreed. Second statement you have said, it's progressive in nature. What do you mean by that?
Sir, initially, according to the mother, when she used to touch the child was very hot, according to her statement. And also, the first time they went to the local dispensary, in the words of the mother, the fever was around 100. But also, but when he got admitted in the CHC Durg, that in that referral paper, the temperature was written 101.2, and after that it was referred to our setup where the temperature was 102.3. So from that,
okay. I wanted you to say the fever was not remitting rather than progressive. That's not a correct word. That is number 2. Third is, what do you mean by partially responsive to medications, and what's the significance?
Sir, partially responsive to medication, sir, it can mean that according to the mother, the fever came when she used to give the medication provided by some first from the local dispensary.
What is your interpretation?
Sir, the fever came down, but the child never became normal. The fever came down, but it was not exactly normal.
Okay, Dr. Srishti.
Yes, sir.
I'll give you a case scenario.
Yes, sir.
There are 2 children who have fever for a day. 2 children in your clinic in front of you. Both have fever for 1 day. One mother says, doctor, I give paracetamol. Fever comes down, but it again comes back. Another mother says, doctor, Whether I give paracetamol or not, fever is the same. What is the difference between these two cases? Both have short duration fever.
Yes, sir.
One responds to paracetamol, one does not apparently respond to paracetamol. What's your...
Sir, it might point to etiology. Paracetamol, the role of NSAIDs in any kind of fever, as it is not responsive to paracetamol, it might give an idea to the etiology, whether it is viral infection or a bacterial infection.
So which one is viral and which one is bacterial? As per your
Non-responsive to non-responsive and still high grade is of viral etiology. In viral fever, then the initial grade of fever is very high, and after a course of illness, it gradually reduces. However, in bacterial infections, unless there is a septic foci, generally the bacterial infection initially it is of low grade.
Okay, Dr. SRISHTI, the reason why I asked this question is to, I would say, burst a myth among students as well as practitioners. What is that myth? You will be surprised. Studies have shown whenever any young child has got acute febrile illness, you cannot differentiate whether the fever is viral or bacterial based on the therapeutic response to paracetamol. For example, I gave you a case scenario where two children are there. The one that responds to paracetamol does not have viral fever, and the one which does not respond has bacterial. You cannot differentiate serious bacterial infection versus benign infection or viral infection based on the therapeutic response to paracetamol. There are good number of studies. It is only your assessment during the interfebrile period which might give clues to the presence of a serious bacterial infection. Yes. So response to medications does not mean anything. Any fever, even if the fever is due to a malignancy, it may respond to a high dose of paracetamol or an ibuprofen.
Yes, sir.
Okay.
Yes, sir.
Right. Then you have said that it was not associated with chills and rigor. What does it mean? If chills are not there, rigor is not there, what does it mean?
Sir,
if they are there, what does it mean?
Sir, chills is a subjective condition, and rigor is the actual manifestation in which contractions can be seen. It might present as generally a presentation of intermittent fever or septic fever in which intermittent bursts are present, such as in UTI or and in cases of malaria where the initial pyrogenic factors spike results in all these cases.
Okay. I want to drive home an important point. Presence of chills and rigor or absence, vice versa, again has very poor localizing value to the etiology. If there is any sudden rise in temperature, particularly when the environmental temperature is low, anybody can have chill, anybody can have rigor, particularly in older children. Of course, an abrupt rise, as in malaria, UTI, any pus anywhere, filariasis, thrombophlebitis, pyrogens due to blood transfusion, particularly when there is a cold environment, you can always get a chill and rigor. There is very poor localizing value. It only tells you the fever is high and it is going up very fast.
Yes.
Right? Okay, rest of the negative symptoms you have mentioned. And what about you have said that the child was not very playful in between episodes.
Yes, sir.
You said not very playful. That means mildly playful. Is that what you wanted to say?
Yes, sir.
Yeah. But instead of saying that, was the child ambulant?
Yes, yes, sir. The child was ambulant. He has a younger sister.
Was he going to the toilet to pass urine or motion comfortably?
Yes, sir. From
Okay, fine. If you had mentioned that, fine. Okay. The second symptom, fever was there, and then cough started.
yes,
To cough again, I'm going to ask you. You have said cough is acute, continuous, but not related to a medication. What
yes.
does it mean? Okay,
Sir,
there are two children with cough. Wait. There are two children with cough. One child gets better with medication, one child doesn't get better with medication. What does it mean?
So cough is a protective reflex, and the presence of cough.
Oh, what is the difference for you? One who responds to medication, one who doesn't respond to medication.
Sir, responsive to medication points more towards an airway pathology, whereas non-responsive.
No. Again, like I said, for paracetamol and viral is bacterial. I mean, response to medication in cough doesn't mean anything. Except when you have cough due to an airway disease which is hyperreactive, like asthma, where you give beta agonists, yes, there may be immediate relief. That doesn't mean anything. Okay?
Yes.
Right. Non-productive and aggravated in supine. What is the significance of cough getting aggravated in the supine position?
Sir, aggravated in supine position, sir, it generally points that it might be caused due to gastroesophageal reflux disease or any cardiac issue or any postural drainage issue. It when the child used to lie, that there was a more drainage in the area, and which leads to irritation, and that to clear the secretions, cough exhibits as a protective reflex.
Basically, any cough which is aggravated in supine position may be because of 2 or 3 reasons. One, it may be because of a postnasal drip. Any postnasal drip coming from the upper airways, the cough may be worse when the patient lies down. Okay.
Yes.
Or, as you rightly said, anybody who's got cardiac failure, who's got pulmonary edema, the cough may be worse during the supine position. Okay.
Yes.
Similarly, if there is, I mean, however rare it is, we have, suppose there is a suppurative lung disease in the upper lobes.
Yes.
Upper lobes. When the patient is sitting up or standing, there may not be cough.
Yes.
On the other hand, an upper lobe bronchiectasis, a patient lies down, cough may be worse. That's why upper lobe bronchiectasis is often called as bronchiectasis sicca. It doesn't cause much cough, it doesn't cause much expectoration, dry cough only will be there.
Yes.
Okay. Diurnal, what is the significance of diurnal variation?
Sir, it is the child's ages of 5 years of age group. Diurnal variation signifies that if there is variation in mornings and evenings, generally in cases of hyperreactive airway disease, due to the pooling of secretions, there is more cough in morning times as in comparison to evening times. So a diurnal variation can give a clue towards a hyperreactive airway disease.
I'll give you 3 scenarios. You have to tell me what is the cause for the cough.
Yes.
One, child starts coughing in the morning, but it becomes worse towards the evening. Second, the child coughs only during sleep. Third, child coughs violently during the daytime when the child is awake, but it's completely normal during sleep. Can you make a diagnosis of all the 3?
So the child starts in the morning and it gets worse, and it gets relieved during the evening.
No, it's worse. It becomes worse towards the evening. Sinusitis towards the evening. Nocturnal cough, again, nocturnal cough, you have only 3 groups: asthma, postnasal drip, and GER. The one who doesn't cough in the night at all is habitual cough or psychogenic cough.
Psychogenic.
Okay. Right. Why did you ask for hoarseness of voice?
Sir, it might give a clue about some laryngeal pathology.
Okay. Will laryngeal lesion produce violent cough? So much of cough?
Sir, in cases
No,
of
no. Very unusual. It's okay. Not associate. No association with meals. What does it signify?
yes, sir.
What does it signify?
Sir, means sir, gastroesophageal reflux disease. Sir,
Okay.
in
Okay.
GERD cases.
Okay. Okay. Go to the next slide.
Yes.
Yeah. Then the third symptom of difficulty in breathing started, which is again more in the supine position.
Yes, sir.
Okay. You said the child preferred to sleep in the left lateral position. What does it signify?
Sir, it might signify the compression of the contralateral side in cases when there
Compression.
is
Compression.
might signify, yes, sir,
Huh?
or compromisation of the contralateral side.
No, I don't understand. See, mother said the child
Yes.
preferred to see, child has got fever, cough, breathlessness, and
Yes.
child preferred to sleep on the left. What are the possibilities? That's what I'm asking you.
Sir, there was difficulty in breathing in the supine position, and there might be accumulation of some fluid or pus in the pleural space, which is compressing the lungs. And when he sleeps in the right lateral side, the normal lung is compressed. But while he sleeps in the left lateral side, the right.
You should not go beyond localizing the pathology in the left side. That's all.
Yes, sir.
The child prefers to sleep in the left lateral position. It might be because of empyema, it may be because of pneumothorax, it may be because of pneumonia with pleurisy, okay, or it may be because of bronchiectasis. In all these conditions, child would prefer to sleep on the left. For example, if there is pleurisy, it is splinting of the chest. And there is bronchiectasis, again, it is to avoid cough. The child is lying on the left side.
Yes.
That's all you can say, right?
Yes.
And what about, why are you talking about seasonal variation in a child who's got only 10 days of illness?
Sir, there was no similar history,
in this symptom, you shouldn't talk about seasonal variation. It's
okay.
only
Yes.
Right. Difficulty in breathing was followed by chest pain 3 days back, sharp, aggravated, more on the left side. I want more details about the chest pain. What is the cause for the chest pain? What do you think is the cause for the
So in the chest, pleura is the structure, this parietal pleura is the structure which is supplied by the nerves. So it might point that the anatomy of the lesion, it's more towards the pleuroparenchymal disease.
I'm saying this is cardiac pain. Cardiac pain.
Sir, a cardiac pain would be more of a dull itching type. The radiation of the pain is quite significant in the cardiac pain, which radiates towards the left side, while it is of a dull itching kind of pain.
Okay, the pleural pain will not radiate to the shoulder.
Sir, it might radiate to the.
Okay. Anyway, this is how we examiners, we always ask questions. Now tell me, child has got chest pain. What are the common causes of chest pain in children, and how do you differentiate? And what do you think is the cause for pain in this child?
So the causes.
Okay, but there is to save time. You must always understand chest pain in a child. In fact, recently there was a beautiful article in JAMA, it's available free, on chest pain in children. Beautiful, simple article, short article. Basically, you must remember chest pain in children. The fundamental point one must remember is that most often non-cardiac than cardiac, unlike an adult chest pain. Point number one. Yes. Point number two, chest pain due to a cardiac lesion may occur in the retrosternal region, may radiate to the shoulder, and It's an anginal chest pain. An anginal chest pain is very rare in pediatrics, and it can occur in any condition where there is a decreased pulmonary or systemic blood flow, like aortic stenosis, pulmonary stenosis, or severe tetralogy of Fallot, or severe anemia. It's very unusual to have chest pain. That's cardiac chest pain. Or it can be something like Alcapa and cardiac, right?
Yes.
On the other hand, a chest pain due to a neuromuscular disease, musculoskeletal disease is much more common. For example, you have the epidemic myalgia or Burn-Holmes disease, Coxsackie, influenza. Many of them can cause costochondritis. That's more common, muscular. And the third is, of course, a pleuritic pain or a pericardial pain. Pleuritic pain can also radiate to the shoulder, and it is aggravated by coughing, and it varies with the phases of respiration. When the patient takes a deep inspiration, pain will be worse. So these are the points. And sometimes your chest pain may be due to skeletal structures, can be due to lesion in the spine, peritoneal masses, the posterior mediastinal tumors can also have neuritic chest pain, neuroblastoma, etc.
Yes.
Right?
Yes.
Okay. Next you said no history of cyanosis, joint pain, or similar illness. Go to the next slide. And finally, please go to the previous slide. Always, please go to the previous slide. Yeah.
Yes.
After mentioning the symptoms,
Yes, sir.
you should always mention what is the present status. After all this, what happened? You should conclude and then go to the past history. Make it a habit. Okay?
Yes.
Go to the
Yes.
past history.
Yes.
Go to the past history. Yeah.
So there was history of varicella infection 1 month back, which resolved spontaneously with symptomatic treatment. There was no other history of any drug intake or history of blood transfusions.
Okay. How was varicella diagnosed?
So they went to a local dispensary near their house. There they were told chicken pox hai, and also, sir, there is this.
What is the description of the illness they gave?
So they gave that the child was there was a breakout in the region, and other children in the neighborhood suffered the same. There was a positive sibling history also present.
I'm saying this. It was hand-foot-mouth disease. What history? How did you come to a conclusion it is varicella? What is a typical history you get in varicella?
Sir, in varicella, there is a prodrome of symptoms. It is a viral infection. Hence, a prodrome of symptoms of fever, rhinorrhea, coryza are present. And the lesions, generally the lesions in varicella, they first start from chest. It is of a centrifugal distribution in comparison to other exanthematous fevers such as rubella, the measles, in which the distribution of is centrifugal. However, it was not told by the mother. The lesions have left the scar in the child, which has a central pit present. Generally, the scars of hand, foot, mouth disease.
Okay, I agree with you. See, basically, the point that I wanted to drive home is that do not go by the statement made by the mother that somebody made a diagnosis of varicella.
Yes.
You have to verify. In fact, the clues that it could be varicella could come, as you rightly said, outbreak of similar cases. Second is, in varicella, fever is not a very prominent symptom. The typical vesicles in the trunk and back are the clues. You don't get lesions in the palms and soles. If palms and soles are involved, then you always think of something like rickettsia or hand-foot-mouth disease. That is another history you should have taken.
Yes.
Fever is not a prominent symptom. As you rightly said, scab formation history, multiple cases, yes. Okay. Next sentence. Next slide. Yeah, antenatal normal, postnatal normal. Next one. Development, okay, fine. And see, the other point, please go to the development history slide.
Yes, sir.
Always, students have a habit of only talking about development. It is wrong.
Hmm.
Development should always be accompanied by growth. You should have inquired about the weight gain of the child, height gain of the child, and
Yes.
even the head size of the child. That is where I said you are apparently all right, can be correct. Only if the child has been gaining weight normally, gaining height normally, and going to school and performing well in school without any exercise tolerance. I assume that everything is fine. Is it correct?
Yes.
You should have mentioned that. Okay, next
Yes.
slide. Next slide.
Sir, I wanted to ask this question. Sir, we can ask the parents about the weight gain and height gain. Do we need the documentation of the same because the child belongs
So
to?
if you have a document, for example, if they have a nice growth card, you can go through. You can tell the examiner, when I took the history, I saw the growth card. You are permitted. You
Yes.
are permitted to go through. Okay, evidence is evidence. Right?
Yes. Thank you, sir.
So, next slide. Nutrition. Okay, I appreciate you. You have taken the pre-morbid and morbid diet. But what is lacking is that what happened to breastfeeding, when was complementary, all this is important in this child. So I assume everything was okay. The other thing is you should talk about micronutrients in this child, particularly in a child who's got breathlessness, comorbid anemia due to lack of iron. Okay, could be a factor. So don't forget micronutrients.
Micronutrients. Yes.
And allergy also should be included in the diet.
Yes.
Next one. Immunization omit. Next one. Next one. Family history. Yeah. Particularly when they're 4-membered means what about the sibling?
Sir, it is a 2-year female child. She has a younger sister.
Normal or alive and healthy?
So normal child, with normal development and no other factors associated, playful. We examined that child also.
Fine.
Yes.
Any history of contact with TB?
Sir, there was a presence of contact of TB in the grandfather of the child. However, he has died way before the birth of the child. So
That
I
is
have
not contact. That is not contact. So
Yes.
don't talk about contact. Okay,
Yes.
fine. Right. Any other family member having a similar illness? No.
No, sir.
Okay, go to the next slide. Socioeconomic, everything. Okay, now I'm going to stop here and ask you,
Yes, sir.
what is your inference from the history? I want to know what is your diagnosis at the end of the history. I'm going to invite Dr. Ajay KOSAM. Sir, you want to ask any questions? And I'm going to ask SRISHTI to sum up the history and give a diagnosis. Dr. Ajay KOSAM.
Yes, SRISHTI, one or two points I wanted to ask.
Please
You had
go ahead.
mentioned that there is history of chest pain in this patient. So as per the symptomatology, it looks like a respiratory system involvement,
Yes.
quite obvious. So in this particular case, what could be the 2 or 3 causes of chest pain in this particular case scenario, which you have presented?
Sir, it might be a case of pleurisy might be a cause.
Okay.
And sir, no other cardiac factors could have been evaluated, but it is in case of infectious disease in a child. So pericarditis can also be taken in a DD of chest pain in this child. We cannot remove pericarditis as a cause before just by history, because it is a case of child. And also, sir, pneumonia can be a cause which can cause parapneumonic effusion, and that parapneumonic effusion can irritate the pleura and result in chest pain.
And already pleuritis you have mentioned. Any other reason can cause chest pain in this case scenario? It is an infectious physiology, quite obviously.
Yes, sir.
So one is pleuritis, second is pericarditis, and third one is, which is very, very rare, that is not very common, you will not encounter in your lives also, which is a complication of the condition which we are discussing. A rare complication mentioned in the books, that is mediastinitis. So these are the 3 possible causes of chest pain: pericarditis, pleuritis, and mediastinitis. That is very, very rare. Suppose the child is having mediastinitis, then what symptom will be having?
The other mediastinal associations would be present.
So what symptoms you will be having chest pain definitely.
So then the symptomatology and the chronology of symptoms might be altered, and the chest pain should be out of proportion to the other symptoms associated.
Okay. And chest pain is usually retrosternal in this case and associated with what? Dysphagia. Okay, because mediastinum structures include esophagus also.
Yes, sir.
So apart from other symptom, if you are having chest pain, high hectic fever, child is sick and is also having difficulty in swallowing, that could be a rare complication, that is acute mediastinitis, a known complication of complicated pneumonia.
Pneumonia.
Okay. How will you differentiate a pericardial pain from pleuritic pain?
Sir, pericardial pain would not differentiate in phases of respiration. It has no relation with the inspiratory or expiratory phase, while the pleuritic pain, it is more in the in inspiratory phases. Or if we also, as the pleural distribution and the the cutaneous distribution of parietal pleura and skin is by same, if we put compression over the chest, in pleuritic chest pain, it has a response to it, which does not have a response in pericardial pain.
तो pericardial pain worsen कब होता है और improve कब होता है?
So it on sir bending forward, it improves.
Yeah, it bending forward position it improves, in supine position it is worse. Okay, and
Yes.
sometimes you can have a referred pain in the abdomen also.
Yes, sir.
Of the pleuritic pain.
Pleuritic pain.
So how does it refers to the abdomen and sometimes refer to the shoulder also? ऐसा क्यों? Pleuritic pain sometimes refers to the abdomen. The patient may be admitted as a case of acute abdomen also, and may be evaluated by surgical department also. Sometimes it happens.
Yes.
They come with abdominal pain. And sometimes come with shoulder pain.
Sir, it is by phrenic nerve only, so it might be a case of that. Cutaneous distribution of the nerves is similar.
Well, basically what happens that if there is an inflammation of the central part of diaphragm, the pain is referred to the shoulder. If there is inflammation of peripheral part of diaphragm, the pain is referred to the abdomen. So it depends upon the location of the inflammation.
Yes.
I think other things you have clearly mentioned, so I don't think I have much further questions.
What is your inference at the end of the history, Dr. SRISHTI?
So in the end of my history, it is a case of acute illness. By history, the symptomatology points towards a respiratory cause, and by history, it points towards a respiratory cause in the left side of the chest. Also, the chest pain points towards the pleural cause on also. So it might be a combination of a pleural parenchymal disease. So sir, it might be the differential diagnosis includes pleural effusion, pneumonic effusion, and empyema-thoracis.
Dr. SRISHTI,
Yes.
always, one can develop a good habit of asking a few questions, particularly when you're dealing with a child who has a problem related to the respiratory system. The questions are, as you rightly asked, you asked whether it is acute, subacute, or chronic. And the classical difference between acute, subacute, and chronic is based on the duration of the illness. Anything less than 3 weeks is considered to be acute and respiratory. 3 weeks to 3 months is subacute. Okay, more than 3 months is chronic. So this is acute, number one. Second is, which are the systems which are involved in this child? I mean, before even the system, is this congenital or acquired?
Sir, previously there was no such episode.
Is this congenital or acquired? Is this
acquired, sir. Acquired.
Acquired. That is number two.
Yes.
Third question is, which are the systems which are involved? It is single system or multiple system?
Sir, towards the symptomatology, it is pointing towards the respiratory system.
Respiratory system. Respiratory system. If it is respiratory system, The next question I am going to ask, the respiratory system consists of upper respiratory tract, lower respiratory area. Is this upper or lower or a combination of both?
Sir, more towards the lower respiratory tract.
Lower. If it is lower respiratory, you have larynx, trachea, bronchi, bronchioles, alveolus, pleura. Which is involved in this child?
Sir, pleural pathology.
Pleural pathology. I am saying it is not pleura. It is initially airway, later parenchyma, later pleura.
Pleura. Yes, sir.
Why am I saying that?
Sir,
everything started with cough and fever.
Yes, sir.
Then breathlessness appeared.
Yes.
Then chest pain appeared.
Chest pain occurred. Yes, sir.
So cough is the first symptom. So you can't ignore airway involvement in this child.
Yes, sir.
And the other thing is this unilateral or bilateral?
Sir, unilateral.
Right or left?
Left.
Now next question is, what do you think is the etiology?
Sir, in infective etiology.
Infective etiology. Which infection?
Sir, in children of 3 to 5 years of age group, strep pneumonia infection is common.
Most
So
common
is strep pneumonia.
Community acquired pneumonia.
Community
Is
acquired.
hospital acquired or community acquired?
Sir, community acquired.
This is likely to be a community acquired pneumonia
Yes.
involving the left lung and pleura, causing parapneumonic effusion or empyema.
Yes, sir.
The most common pathogen being pneumococcus. The only thing is, this child is getting treated for so long. What makes you think beyond it? Should make you think beyond pneumococcus? So what other organism will you suspect other than pneumococcus?
Sir, the child has a history of varicella infection, and the varicella infection has a temporal association with staph infections also.
Excellent. In fact, that is what I wanted you to say. Connecting the varicella and the pneumonia, you have to look beyond pneumococcus, a community-acquired MRSA infection. Community MRSA infection.
Sir, I wanted
or a streptococcal. In fact, varicella is notorious for causing even increase in group B streptococcus, group A streptococcus, and varicella. Okay, right. Yes. Go to the physical examination.
Sir, I wanted to ask something. So the child's age is of 5 years of age group, and in the national immunization schedule, the pneumococcal vaccine was introduced in 2017. In our state, in Chhattisgarh, it was introduced in the year 2021 of June. So my patient has not received vaccination for pneumococci. So sir, can it be more pointing towards the pneumococcal infection as if he had been?
You can't. In fact, if you go to the net and read, even developed countries like UK, USA, there is an increase in necrotizing pneumonia caused by non-vaccine strains of pneumococcus.
Yes.
19F and other things. So just because vaccines have been given, it doesn't mean you can't get pneumococcal.
Yes, sir.
Please go to the presentation.
One more important thing to understand that pneumococcal vaccine mainly protects against invasive pneumococcal infection.
Yes, sir.
The protection of pneumococcal vaccine against pneumonia is lesser as compared to invasive pneumococcal disease. Sepsis.
Yes.
Okay. The second important point I wanted to ask that based upon the onset, duration, and progression of the illness, can you probably assess the etiological agent, onset, duration, and progression of the disease, which you have already described? Can you point out the organism, that is pneumococci, whether it is staph, whether it is H. influenzae, whether it is streptococci?
Sir, all these organisms have a different progression, different type of progression. In strep pneumoniae infection, it causes more of it causes edema of the adjacent structure and produces a confluent distribution in the entire lobe. Hence, lobar pneumonia is more common in strep pneumonia infection. In
No, I'm
staph
asking
infection,
about the progression. We're not discussing about because you're not going to the examination.
yes, sir.
On the onset, duration, and progression. We have not discussed the examination part. We don't know it is lower.
On the basis of progression, it can either be a staph infection or a group B streptococci infection, because both or a strep, because all of them present as confluent pneumonia. Group B streptococci infection being the most important cause of a rapid progression.
Dr. Shrishti, one correction.
Yes.
It's actually Group A. Group A. Group B
yes,
is perinatal.
Yes,
Group
sir.
A, beta
It's
hemolytic.
perinatal. Perinatal. It's
Yes.
not. It's not in older children, but it can occur. But Group A.
Yes.
See, two
Yes.
things. One, see, garden variety pneumococcal pneumonia doesn't behave the way it has behaved in this child. With the background of chickenpox, you should, in this child, you should think beyond pneumococcs. Think
Yes.
beyond pneumococcs.
Pneumococcs.
And H flu with vaccination, typable H flu pneumonia is exceedingly rare. You have to think of staphylococcal pneumonia.
Yes, sir.
And of course, other than staphylococcus, pneumococcus, and H influenza, the 5-year-old child, complicated pneumonia can be due to mycoplasma. Earlier, people used to think that mycoplasma pneumonia does not cause pleural effusion. It's not so. I believe in 25% of cases in mycoplasma, you can have pleural effusion. But recent articles from China, leave alone the epidemic which is going on, have shown that mycoplasma pneumonia is quite the common cause of necrotizing pneumonia. It can coexist along with pneumococcus or even staph. Please go to the general examination.
The child was ill-looking, conscious, oriented, of normal stature, with slight tilt to the left side. The vitals being 102 degree Fahrenheit. The pulse rate was 160 degree, was 160 per minute, regular in rhythm, normal volumic, with no special character, felt in all the peripheral areas. Respiratory rate being 58 per minute. Blood pressure was 100/60, which was noted in the supine position in the right upper limb. Noted in the sitting position. The capillary refill time was less than 3 seconds, and the saturation pulse oximetry on room air without oxygen was of 88%.
Go ahead.
Yes.
Please go ahead.
The anthropometric evaluation is of normal. The weight is between -1 standard deviation to 2 standard deviation. The height is also in the median range, in the range of median to -1 standard deviation, with the weight by height between 1 to -2 standard deviation, and mid upper arm circumference being 15 centimeter.
Okay.
The head to foot examination, nutritional status average, build is average. The head is normal with no other facial dysmorphism. Hair was black, non-lustrous. Eyes and ear normal. Nasal flaring was present. The child was breathing through mouth. Dental caries present. No obvious neck swelling was present. And the neck is centrally placed. No chest wall or deformity present. Spine central is and normal, with no presence of either pallor, icterus, cyanosis, lymphadenopathy, or edema.
Go ahead.
Yes.
Can you go back to just go back to these vital signs? Just go back. Vital signs. Okay. You have mentioned child is toxic and sick looking, and
Yes.
there is high fever 102 and a pulse rate of 160. So with a fever of 102 and a heart rate of 160, do you think that the pulse will be of normal volume? I don't think so.
Hypovolumic.
102 fever.
Yes.
Patient looking toxic, at pulse rate is 160, the blood pressure is 100/60, that is normal. So with a high fever, normal pulse volume, I don't think the pulse volume should be normal. कैसा होना चाहिए pulse volume in high fever?
Hyperdynamic, sir. Fever is a hyperdynamic state.
So there should be a bounding pulse. I was expecting a bounding pulse in this patient because such a high fever, usually the pulses are bounding in this patient because of vasodilation. And you have mentioned blood pressure 160, the pulse pressure is normal. Okay.
Yes, sir.
So what is the association of pulse pressure with the pulse volume?
Yes, sir.
And what are the factors that determine the pulse volume?
So the
They have
volume of
mentioned-
the pulse will be dependent in the circulatory blood volume and in the peripheral vascular resistance.
Okay, so if there is high fever, what will happen to vascular resistance?
So vasodilation should occur, compensatory vasodilation.
So what will happen to pulse pressure?
So the pulse pressure should increase.
Increase. So if there is increased pulse pressure, what will happen to the pulse volume?
Hypervolume of pulse.
It should be bounding.
Bounding.
Because volume depends
Yes.
upon pulse pressure and cardiac output. Okay. So इसमें cardiac output, high cardiac output state होगा ये because there is high fever and
Yes.
infection है, तो infection में भी cardiac output बढ़ जाएगा. Plus
जी,
there is
sir.
fever. So I would be expecting a bounding pulse in this child.
Okay.
So you just examine the pulse once more if you have not examined.
Yes, sir.
Yeah.
Yes.
Next.
Sir.
Next.
On systemic examination, inspection of the upper respiratory system, nose, was normal in shape, no nasal discharge present, nasal flaring was present, pharynx was normal, no palatopharyngeal incoordination was noted, and the tonsils were normal. Lower respiratory tract inspection, the type of respiration was abdominal with increased respiratory effort seen. Intercostal and subcostal retractions were present.
What do you mean by abdominal type of respiration?
Sir, the movement of thorax is less in comparison to abdominal.
It is. You should only say abdominothoracic.
Thoracic. Okay.
Because if thorax is not moving, there's something grossly wrong.
Yes.
You can't say respiration is abdominal.
Yes, sir.
You say respiration is abdominothoracic.
Thoracic. Yes. Flaring of Allen present.
What is the normal type of respiration in various ages?
Sir, in children of 3 to 8 years of age group, thoraco-abdominal type of respiration is present, and in from adolescent age group, the respiratory efforts are predominantly abdominothoracic. It also varies towards the sex also. In females, there is more prominent of thoraco-abdominal respiration.
Okay. Go ahead.
Yes, sir. Shape of the chest was asymmetrical. There was slight bulge present in the left side of the chest, and the movement in the left side of the chest was decreased. There were no visible deformities in the chest wall. The apical impulse was seen in the fifth intercostal space, medial to the midclavicular line, and the fullness of intercostal spaces were noted in the left side, with the trail sign being present in the right side.
You have a video or a photo of the child?
No, sir. Actually, we have shifted the child to other facility.
Okay.
Examination of the back. The spine is midline. The shoulder is symmetrical to the both sides. No scars were visible or dilated veins were visible. On palpation, the local temperature was raised in the left side and tenderness was also present in the left side. The tracheal position was confirmed. The inspectory finding of trail sign was confirmed, and the tracheal position was shifted to the right side. The chest expansion was decreased in the left side. The chest circumference on inspiration was of 62 centimeter and expiration 60 centimeter. Vocal fremitus was absent in the left side. In the back, the spino-scapular distance in the right side was 4 centimeter and in it was around 4.7 centimeter. On percussion, a stony dull note was present in the infraclavicular, inframammary, and infraaxillary and axillary and clavicular area of the left side. On auscultatory findings, there was decreased air entry in the left side of the chest in infraclavicular, mammary, inframammary, axillary, infraaxillary, and subscapular region in the left side. There was absent vocal resonance in the left side of the chest. No voice sounds were present and no other additional sounds were present.
Wait. What do you mean by the term decreased air entry? Which clinical methods book describes such an entity called decreased air entry? Give me a reference.
Sir, it in comparison to the
Give me a reference.
Huh?
SRISHTI's textbook of pediatrics. Okay, there is no such term as decreased air entry. But strong message to postgraduates, do not use the term decreased air entry. It is used only by intensivists who don't carry a stethoscope. Right? Students, postgraduates should always say decreased breath sounds. There's nothing called air entry. Please stop using the term air entry.
Yes, sir.
Breath sound, decreased breath sounds. That's what you should use.
Yes.
Okay. But you're not mentioning anything about infrascapular region and suprascapular region and interscapular region.
So the breath sounds
even if they go to the previous slide. What do you mean by voice sound?
Sir, the breath sounds are produced
What do you mean by the term voice sound?
Sir, voice sound is a sound that is produced.
There is no such thing as voice sound.
Okay.
There are only vocal resonance. Okay, avoid using such loose terminologies in the examination. Please go to the next previous slide.
Yes.
Stony dull, you have not mentioned anything about the scapular region.
Sir,
only in the front there is dullness. What happened to the back?
Sir, I was not able to delineate it properly, so I have not mentioned it.
Oh God.
In comparison to the other side, I was not able to delineate it.
Go to the previous slide. Please go to the previous slide. Okay, right. What about vocal resonance?
So vocal resonance was absent. There was no pressure waves was absent.
Okay, go ahead. No, 1 minute.
You on the entire left side, you are not able to hear the vocal resonance, absent vocal resonance on the entire left.
Sir, vocal resonance was not heard appropriately left side when the comparison was made to the right side. I could not delineate. It was not even heard properly, so that I can say that it was decreased in comparison. I was not able to hear the sounds properly. Hence, I have.
Dr. SRISHTI, Dr. KOSAM is sending home a very good message to you. In a 5-year-old child with such a small chest, the vocal resonance never becomes absent. Sir is conveying a very good practical point. Only markedly reduced. I don't think it can completely disappear unless there is no lung at all on the left side. That doesn't happen.
Yes.
Sir has nicely pointed out the mistake you have committed. Don't say absent.
Yes.
I don't think you can completely get absence of breath sounds or vocal resonance on one side, even if there's a massive pleural effusion.
So sometimes on auscultation in a patient where you are suspecting there is a pleural involvement on one side, what findings do you actually expect? Suppose this was a 10-year or 11-year-old child with the left-sided pleural pathology, and you're auscultating the patient.
Yes, sir.
So what findings are you expecting apart from what you have already mentioned?
Sir,
Decreased vocal resonance, etc.
Sir, if the pathology is plural, we will think about two factors of sound, the progression of vibration as a sense and sound. Vibration travels most fast in air, while sound wave travels most fast in the sound. In case of plural
I'm
pathology,
just asking about the finding which you will be expecting.
sir, if there is presence of a pleural pathology such as pneumothorax or a pleural effusion, the distance would be in, hence the vocal resonance will be decreased. A vocal
So
resonance and vocal
any other
will be
finding which
decreased.
you will be expecting apart from the vocal resonance? Any other finding you will be expecting?
Sir, any other finding on auscultation or
Yeah, auscultation.
on pleural effusion?
Yeah.
Sir is giving a very good clue. He's a liberal examiner. He is trying to rub your brain.
Sir,
He's
any
trying to
other
create a
added
rub.
sound? Plural rub,
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 plural rub.
rub.
Plural
Any other
rub.
thing?
Pericardial. In this child, you should try to elicit a pericardial rub, pleural rub, and of course a succus and splash, shifting dullness, horizontal dullness. All these signs you should coin sound. You never know whether there is only pneumothorax, only
What is called as
hydrothorax, or there is a hydropneumothorax.
Yes.
And bronchophony and egophony. What are those?
Sir, bronchophony and egophony are sir, types of vocal resonance. In bronchophony, the high frequency sounds are not cleared. Alveoli acts as a filter which clears the high tones out. In bronchophony, the high tone sounds are not filtered out. So when we hear the sound, it is heard as a very clear sound. While egophony, in egophony, a partial nasal characteristic is imparted to the sound. So any sound which comes as E on auscultation, it comes as A due to dampening of the sound waves in due to the pathology.
So why it happens? What pathology? Because plural side में तो कुछ नहीं है.
Sir, in bronchophone, in cases of consolidation, there is fluid present, and generally air is filled in alveoli. If air is replaced by fluid acts as a better conductor of sound, and it crosses the effect of alveoli, which dampens the high frequency sounds. Hence, the high frequency sounds are properly conducted, and fluid being the better conductor, we can hear the sounds and of not of high frequency also.
Basically, because of fluid, there is partial collapse of the lung. So the lung solidifies, air divides of air. That's why you get the findings of consolidation. Basically, actually, this bronchophony is a finding of consolidation.
Yes, sir.
But sometimes you may get them in cases of pleural effusion because of partial collapse of the lung in that area. And one thing I also want to understand, you have mentioned that there is a absence of breath sound on the left side and the heart sounds are also heard. I'm not very sure. Heart should have been on the right side, slightly on the right side or the middle side of the chest.
Sir,
You are saying that the apical impulse is visible on the left fifth intercostal space. I don't think so. With the findings you are telling, complete absence of vocal resonance, no voice sound present, decreased air entry on the left side, I will not be expecting the heart to be present in the left fifth intercostal space.
sir,
It should
it
have
was
been
not
shifted toward the
present
center side.
laterally, but it was present medial to the mid-clavicular line. In this age group, we should expect
She had mentioned medial shift of apical impulse.
medial shift.
Sir said expect more. 1 centimeter medial to mid-clavicular line. That's what she said. 5-year-old child, you expect this to be in fifth space, in the mid-clavicular line, or just still outside. Here it shifted medially, but as Dr. Kusum pointed out, you expect this to be a massive effusion where nothing, breath sounds are not heard, and definitely you expect more of a medial shift to the right side. Okay. The other thing I wanted to ask you, was there crowding of the ribs?
Sir, on examination, sir, there was fullness of. Yes, sir. Fullness of intercostal spaces were present.
Was there any tenderness over the intercostal region?
Sir, in left side, there was a superficial tenderness present.
Okay.
The child was not.
Unfortunately, Dr. Kusum, we can't verify and confirm the findings.
Yes, sir.
Okay. We will accept whatever she says. Abdomen. Findings in the abdomen.
So there were no significant findings in abdomen.
Okay.
System examination was normal.
Okay. Okay. Did you percuss this child?
Sir, I tried to percuss it, and all the inferences I made accordingly to that only. However, the child was not much cooperative, so I cannot be very much assured about my findings.
Okay. In percussion, in this case, there is one physical finding and one area you should percuss. What is that?
Sir, it is of left-sided effusion. So, Traub space, sir.
What is Traub space? What is anatomically space?
Sir, anatomically, Traub space is occupied by the stomach, and the node should be in the tympani. The node should be tympanic due to the gas in the stomach. In cases of left-sided pleural effusions, if there are, if it is a large pleural effusion, the boundaries of the Traub space, which is laterally by this by spleen, medially by left side of the liver, and it is obliterated in cases of left pleural effusion. So the node shifts from tympanic to dull.
Actually, if you're asked what is Traub space, your answer should be it is a semi-lunar space. Semi-lunar space. Okay. And
Yes.
it is bounded above by the pericardium and the left pleura. And a full stomach may occupy, or it may be occupied by a pericardial effusion or a pleural effusion. Okay. And it is just below the apical impulse.
Yes.
Apical impulse. And in a normal person, in an empty stomach, in the sitting position, Traub space is usually resonant. Even if somebody takes a full meal and if you percuss the Traub space may be obliterated. Traub space may be obliterated by full stomach, pericardial effusion, pleural effusion, sometimes rarely massive collapse of the left lung also. Can even be pulled up.
Yes, sir.
Okay, right.
Yes.
Go ahead. Yeah, sum up your case and give a diagnosis.
Sir, by history, 5-year male child, belonging to the poor socioeconomic stature with the status with complaints of fever, cough, difficulty in breathing, and chest pain in the left side of chest. And by examination, the ill-looking child with increased respiratory efforts with decreased chest movements in the left side. On examination, there was bulging of chest noted in the left side of the chest with decreased air entry, with decreased breath sounds, which were present in the left side of the chest, which gives us a differential diagnosis of lobar pneumonia and other differential diagnosis, lobar pneumonia with empyema thoracis. Differential diagnosis is being the parapneumonic effusion, tubercular effusion, or lung abscess. Okay,
no. Now, what do you mean by the term left lobar pneumonia? Which lobes are involved?
The entire left lung was involved. However, sir.
How do you know entire lung is involved?
Sir, on there was bulging of entire by examination wherever.
Bulging of the chest is due to pneumonia, is it?
No, sir, it is due to any pleural pathology which is shifting and which is compressing.
What is your diagnosis?
Sir,
you can only say it is a left-sided pneumonia,
yes,
community-acquired pneumonia with empyema thoracis.
Yes.
You can't say left lobar. You can't say which lobe is involved.
Yes.
Now, once there is an empyema or a parapneumonic effusion, massive, you can't make out which lobe is involved.
Yes, sir.
Only left-sided community-acquired pneumonia.
Yes, sir.
Complicated. In fact, I would put an adjective. Complicated left pneumonia, community acquired, and the complication being empyema thoracis.
Empyema.
How do you differentiate empyema thoracis from a parapneumonic effusion?
Sir, a parapneumonic effusion, generally the amount and response to the therapy would be
You think
better
this
in.
child has got parapneumonia? Very simple. Will parapneumonic effusion cause chest wall tenderness? Will
No,
cause
sir.
complete absence of breath sounds?
No, sir.
Will cause so much of toxemia?
No, sir.
Oh, DD, that's not it. Tuberculosis effusion. What makes you think of tuberculosis effusion in this child? And what are the points against tuberculosis effusion in this child?
Sir, it is a case, sir. Although it was an acute presentation, tubercular effusion should always be put into a differential diagnosis. We can never eliminate tuberculosis just by history itself. We need to proceed to some other investigating features also. So I have put it as a differential diagnosis.
I'll put it this way. I am saying this is not tuberculosis effusion. And why am I saying that?
So the course of illness is acute and the child is very ill looking in tubercular. It is more of a subacute progression.
The most important point that you must remember is that in pediatrics, tuberculosis effusion is never an acutely severe illness.
Yes.
Again, tuberculosis can cause empyema, but it is very, very unusual. And look at the nutritional status of this child.
Yes.
It's good weight, acute onset, very ill child. I don't think I will consider tuberculosis as a possibility. But of course, as your argument, as put by your argument, in India you have to think of it, but you should even think of tuberculosis empyema.
Yes, sir.
What makes you think of lung abscess in this child? And what is against lung abscess?
Sir, the pleural distribution of pain is against lung abscess, but in the continuous ill-looking child and with a prominent
lung abscess never causes this sort of features of pleural effusion.
Okay, sir.
It's got long duration fever. It's a suppurative pneumonia. Pneumonia. The only other diagnosis other than this you could have put holistically is necrotizing pneumonia involving the left lung associated with empyema thoracis. Necrotizing pneumonia. Any non-responding pneumonia beyond 72 hours of good antibiotics, you should always start thinking of necrotizing pneumonia.
Yes, sir.
That should be your diagnosis.
Yes.
Okay?
Yes.
Right. Now, again, for the sake of postgraduates, I would say in any respiratory case, as I said in the history, again, you should start answering at the end of history and physical examination. SRISHTI, you're going to get the diagnosis.
Okay.
Is this an acute problem, subacute, or a chronic one?
The acute problem.
And it is nearly becoming subacute. If I were you, I will say.
It is not, yes, sir.
Well, duration is crossed nearly 2 weeks and it's not getting better.
Yes, sir.
Is primary respiratory or respiratory plus cardiac or other systems?
Sir, primarily respiratory.
Congenital or acquired?
Acquired.
Acquired. Upper or lower respiratory or both?
Lower respiratory tract involvement.
Okay. Airway, parenchyma, pleura, or a combination of more than one?
Sir, a combination of all three: airway, parenchyma, and pleura.
Airway, parenchyma. Right. Then is it unilateral or bilateral?
Unilateral, sir.
Unilateral. What do you think is the etiology?
Sir,
what do you think is the etiology?
sir, an infective bacterial etiology.
Obviously, infective bacterial etiology. Which bacteria is likely? Again,
Sir,
whatever we discussed in the history only.
The staph in relation to varicella.
Staph aureus.
Staph aureus.
Good. My next question is, when do you suspect staphylococcal pneumonia clinically?
Sir, breathlessness was continuous in this child. If a child develops...
When do you start suspecting staphylococcal pneumonia clinically? That's my question.
Sir, sudden breathlessness.
Pardon?
So sudden breathlessness, as staph pneumonia leads to
Okay.
pneumatocyst formation and it can burst suddenly, which can cause spontaneous pneumothorax.
Okay. Basically, you suspect staphylococcal pneumonia in younger children. Two, you suspect staphylococcal pneumonia when the pneumonia is progressing rapidly. For example, you admitted a child this morning with a respiratory rate of 40. By evening, it is started grunting and has developed effusion, that is staphylococcal. Rapidly worsening. Third, when there is pyoderma or abscess in the child, or mother has got mastitis, or somebody in the family has got a staphylococcal infection. Four, hospitalized child, nosocomial pneumonia.
Okay.
Nosocomial pneumonia. You start suspecting. Five, whenever there is an empyema, you always start thinking of a staphylococcal. Empyema,
Yes.
right?
Yes, sir.
These are all the clues to the measles. Post measles, of course, pneumococcus can still occur. You should start thinking of
Staphylococcus infections.
right?
Yes. Yes, sir.
And one more additional point that in Staph aureus, pneumothorax is very common.
Very right. Air leak syndromes are much more. Okay.
Yes, sir.
Right. Sir, Kusum, you can ask more questions and end up.
Okay, so your diagnosis is right-sided left-sided empyemothoracis. So
Yes.
suppose you want to manage this patient.
Yes.
So how will you manage this patient?
Sir, as it is an infective pathology and we are suspecting a bacterial infection and staphylococcal infection, be putting the patient on, first we'll giving the antibiotic coverage, which covers this gram-positive bacilli. Third generation cephalosporin with glycopeptides such as vancomycin, which acts on cell wall, would be a better combination in this. Also, this is a massive, in this case, the child had a significant respiratory distress present with with bulging of chest, and respiratory efforts were increased out of proportion. So we would go for the intercostal chest tube drainage in this child.
So what did you get in this patient? What was the drain like?
Sir, it was a purulent drain. However, but in the first 2 days, the drain which came was partially hemorrhagic. Also, the average fluid drainage daily was of 100 to 150 ml daily, and the air fluid.
Frankly purulent pleural fluid.
Yes, sir, it was a milky white debris kind of fluid, but in the first 2 days, the significant hemorrhage was also present.
So when you say milky white, do you think you should think of something else? It is very rare, but milky white you said, that's why I was telling you.
Sir, milky white can present in 3 types. It can be in chylous causes, chyliform causes, or the milky white causes due to the debris. Sir, in in which the chyliform thorax is produced, it is due to the traumatic cause. In chyliform pleural effusion, it is due to the breakage of fat globules. Due to the breakage of fat globules,
How will you know that it is not a chylous effusion or it's actually a purulent effusion? Milky
sir, we
white, it is
will
milky
go
white.
for
How do you know?
investigative purposes of gram staining and pH analysis studies.
So what it will reveal?
Sir, in chyliform effusion, the prominent cellular debris will be present.
In chyliform and in chylous?
Milky pleural effusion, sir. In chyliform, fat-laden macrophages.
No macrophages. So basically you centrifuge that. If you get a supernatant, it is infective.
Yeah.
If it is still totally milky, there is no sedimentation, it is usually a chylous effusion. And you have to look at the triglyceride level. It is very high if it is a chylous effusion. and the
Yes.
pH is normal.
Normal.
Whereas in that purulent, it would be a low pH.
Low pH.
Okay.
Yes, sir.
Then another important thing to understand that suppose you have done this intercostal chest tube drain, you have given antibiotic. Anything else you want to do in this patient? Because this
Sir,
patient is at a very high risk of some complication. What is that?
Sir, empyema-thoracis has 3 phases. In the fibrinopleural phase, fibrin depositions are formed, which leads to septation. So even if we put the intercostal chest to the loculations present due to septations, proper drainage not occurs. Sir, in that cases, we need to go further for surgery.
No. You cannot directly go for surgical
Sir, go for
intervention.
fibrinolytics, sir. First, we can fibrinolytics. But sir, that facility was not available in our setup.
Go for fibrinolytics. Yeah. So it has been clearly mentioned in the textbooks that only medical treatment will have a problem in the long term. So medical with surgical both should be given together, and it is always, if you are not doing a VATS, it is always preferable to do the fibrinolytic therapy.
Okay, sir.
And this, because it was a frank pus.
Yes, sir.
This is fibropurulent stage, and this fibropurulent stage may have some loculations.
Yes,
So
sir.
you have to do the intrapleural fibrinolytic therapy.
Okay, sir.
So this is the recommended treatment if you are not doing the VATS in this particular patient. Apart from that, this patient, if you want to evaluate whether there is development of septations in the pleura or not, what investigation would you be doing?
Sir, your ultrasound.
Okay, ultrasound. What are the indications of doing a CT chest in a patient of empyema?
Sir, this thickening of pleural line, specific thickening with splitting of pleural lines present.
No,
And
thickened pleura can be easily seen by ultrasound. There is no need for a CT to get a pleural thickening. What are the specific indications for a CT thorax in a patient of empyema?
sir, non-responding cases, sir. Sir, we need to look for the peel which is formed by the fibrin deposits and the cellular debris, which is in which lungs significant lung compromise is present.
So basically, there is a clinical protocol. First protocol is if a patient is having fever with a case of pneumonia, not responding to treatment in 72 hours, you should think of pleural effusion or empyema. You do antibiotic treatment, you drain. And if after drainage, the patient is not improving, you are suspecting that it is a fibropurulent stage, you go for either VATS or you go for intrapleural fibrinolytic therapy. After giving intrapleural fibrinolytic therapy, if still the patient is having persistent fever, the dyspnea is not improving, general condition is not improving, that means that the patient has progressed from fibropurulent to organized stage, or there may be other complication like the development of possibly sometimes lung abscess, very rare, but it may develop lung abscess. So that is the indication for doing a CT thorax. Because before now you are going for surgical procedure, you want to do decortication or you want to open the thorax. So before that you CT thorax, otherwise there is no role of CT thorax before that. So usually what we do is we harp on CT thorax, but the best investigation is ultrasound chest. Okay.
Yes, sir.
You have the X-ray chest of this patient?
Yes, sir.
Please show me.
Yes, sir.
Okay. Yeah, read the chest X-ray.
Sir, it is a chest X-ray of posterior anterior view. The epiphyses are not fused, so it it signifies a child's chest X-ray. There is prominence of vertebral column note, hence signifying a posterior anterior view. or on examination, the trachea, on visualization, the trachea appears to the mediastinum is shifted towards the opposite side, that is the left side. In the right side, in the left side, the normal lung parenchyma is not visualized properly. The costophrenic angle could not be costophrenic and cardiophrenic angles in the right side could not be delineated properly, signifying some pleural involvement.
Okay, 2 or 3 things are very prominent in the X-ray. One, there is a massive mediastinal shift of trachea and the heart. And as Dr. Kusum pointed out, I don't think your apical impulse is here. It is here. It is shifted so much hard. And it's an opaque left hemithorax. So you can't distinguish between the heart shadow and the lung shadow and the abdomen and the diaphragm. That's important. That's important. So this is an opaque left hemithorax. And the moment you get an opaque left hemithorax, it's an indication for an immediate ultrasound.
Okay, sir.
As Sir pointed out, there is enough evidence in literature that ultrasound of the thorax is as good as CT thorax for identifying complicated pneumonia. As he said, you start antibiotics for a garden variety community-acquired pneumonia. Within 72 hours, if there is no response, yes, you repeat an X-ray and then perform an ultrasound. So ultrasound is good enough. Now, throughout the world, they are stressing on avoiding radiation. Except surgical procedure is planned, there is no need for doing a CT at all. CT may give you confirmatory evidence of lung abscess, confirmatory evidence of necrotizing pneumonia, and also rule out underlying diseases like tumors or other underlying problems which give rise to impairment. So the routine CT chest is not
recommended.
Needed. Of course, surgeons, if they want to go in with a laparoscopic, video-assisted thoracoscopic surgery, they would prefer to have complete anatomical details for which CT might be helpful. But other than that, CT and ultrasound particularly done by experienced persons is as good as CT thorax, right? The only diagnosis which you can miss with an ultrasound is sometimes a pulmonary gangrene, sometimes a necrotizing pneumonia, sometimes a small lung abscess. Everything else can be made out with an ultrasound performed by an experienced person. Okay?
Yes.
Right. What about the blood counts? Did they give any clues to the etiology?
Yes, sir. Sir, the presentation was acute, but the child had mild anemia present. So we were evaluating for all the causes. The MCHC of the patient was decreased. In cases of mycoplasma pneumoniae, as an ongoing hemolytic picture is present, we wanted to delineate it further.
Did you do Coombs test?
Sir, the Coombs test was direct and indirect test was negative. Coombs test was also done. Hematological profile was also done. However, IgM profiling could not be done for mycoplasma pneumoniae, and we refer to the microbiological department also. But culture of Eaton-Agar was not feasible in our setup.
Doctor, there are a few points regarding the diagnosis of mycoplasma pneumonia.
Yes, sir.
Mycoplasma pneumonia is an organism which cannot be cultured easily. It's not available. Culture facilities are not available even in the best of centers. 2, PCR from the pleural fluid, PCR from the bronchoalveolar lavage can be a good investigation for proving mycoplasma pneumonia. IgM for mycoplasma is not a useful test because following mycoplasma infection, IgM can remain positive for up to months. The gold standard for diagnosis is considered to be as follows. One, in the presence of clinical criteria fulfilling Mycoplasma pneumonia, if you have a PCR from the BAL or or fourfold rise in paired serology of antibodies to Mycoplasma, then only you can confirm Mycoplasma pneumonia. IgM is a useless test, and in cases like this, most infectious disease specialists would always like to add azithromycin as an add-on drug. Whether it acts on Mycoplasma and improves, or if the child improves because of anti-inflammatory action, it is controversial, right? In fact, again, to quote Chinese literature, 90% of Mycoplasma pneumonia in China are resistant to azithromycin, and they prefer to give doxycycline or levofloxacin. Okay. And Mycoplasma pneumonia is well known to coexist along with pneumococcus. And Coombs test positivity, presence of hemolytic anemia, presence of extrapulmonary manifestations like rash, arthritis, etc., hepatitis, etc., need not be there.
Okay.
It can cause empyema also. It's very well reported in literature.
Yes.
Right? The
Yes.
other test which will prove the diagnosis is, of course, what is called BINAX test, BINAX. It is pneumococcal antigen test done in the pleural fluid. It is supposed to be a confirmatory test for pneumococcal parapneumonic effusion and pneumococcal empyema. You know, in adults, urinary antigen for pneumococcal infection is considered a specific test for diagnosis of pneumococcal pneumonia. In pediatrics, it is not considered a good test for the simple reason below 5 years, children may have nasopharyngeal carriage of pneumococcus, and urinary antigen may be falsely positive for pneumococcus if they are carriers. On the other hand, pleural fluid or CSF or pericardial fluid or ascitic fluid, if it is BINAX or pneumococcal antigen positive, it is considered enough evidence for pneumococcal infection other than PCR.
Yes.
Okay.
Yes, sir.
Yeah. Anything else you want to say, Ma, from the investigations and from the treatment? What happened to this child, you tell us? And
This
the antibiotic choice for this child, you said third generation cephalosporin, agreed. Ceftriaxone is the drug of choice to cover pneumococcus and H flu and methicillin sensitive Staph aureus. And of course, to cover MRSA, you have rightly started vancomycin. But unfortunately, vancomycin is not a very good drug for empyema. The concentration of vancomycin in the pulmonary alveoli is very poor. But infectious disease experts consider vancomycin as a drug of choice whenever you suspect bacteremia. The other alternatives include ceftriaxone plus clindamycin plus or ceftriaxone plus linezolid with rifampicin. A very good anti-MRSA drug. Okay?
Yes.
Right. Dr. Kusum, you want to add anything? Now it's 10:25. Dr. SRISHTI also must be tired with the barrage of questions from both of us. You want to add?
Just last question I wanted to ask. So this child had a massive empyema on the left side.
Yes.
Okay. So you have subjected this patient to intercostal chest tube drain, I suppose.
Yes.
Yeah. That must have revealed a large volume of pleural fluid.
Yes, sir.
So suppose you have drained a very huge amount of pleural fluid in one setting, the patient may deteriorate suddenly. What could be the cause?
Sir, pleural shock, sir, sudden hypovolemia, we need to replace the fluid. And also, sir, tongue with...
Why hypovolemia will happen? That is an exudate, not a transudate.
Pleural shock.
It's an exudate, no? This is not a transudate. This is an exudate.
Sir.
Sometimes what happens is when you get a very large amount of pleural fluid in one setting, the patient may deteriorate suddenly And the reason is something what is called as re-expansion pulmonary edema.
They can
When
die.
the lung is collapsed, okay, when you drain the fluid suddenly, there is sudden expansion of lung, and that may lead to what is called as re-expansion pulmonary edema. That may cause deterioration in some of the patients, but usually we don't drain more than 1 to 1.5 or 2 liters, so that is very rare. But that is important point to understand. If a patient deteriorates after draining a huge amount of empyema, you should think of re-expansion
Pulmonary edema.
pulmonary edema. That is a complication of drainage of large volume of pleural fluid. Okay.
Yes. Yes.
Okay. Anything else, Dr. Kusum, before we conclude?
I think that's all from my side.
Okay. Okay. Very nice presentation, Dr. Srishti. You can go and today read about empyema. There are good guidelines, what are called BTS guidelines, and even necrotizing pneumonia. There are good articles.
Yes.
You can go through. In fact, throughout the world, there is what is called resurgence of necrotizing pneumonia. It's being increasingly recognized, and I believe it has become more after the introduction of the pneumococcal vaccine. Paradoxically, in the developing countries, they are seeing more of necrotizing pneumonia after introduction of pneumococcal vaccine with vaccine stress, with the non-vaccine serotype like 3, etc. 390F and 2022, etc. That's becoming a huge problem. In India, traditionally, we have been seeing necrotizing pneumonia only due to staph aureus. And then most literature reports from India suggest that necrotizing pneumonia is more often caused by staphylococcus in India rather than pneumococcus. And there's not much data on mycoplasma pneumonia from India. As you are seeing in the newspapers, there's a lot of talk about mycoplasma pneumonia in China recently, right? Rarely, adenovirus pneumonia also can cause a necrotizing pneumonia, but it doesn't cause so much of empyema like this. Okay?
Yes,
right.
sir.
Okay. If there is nothing else, Dr. Kusum, you want, sir, anything else, sir, you want to add, sir?
No, sir, I think that's all. Dr. Srishti, very well presented, and I'm very happy with your presentation.
Okay, sir.
Very good. Thank you very much, Dr. Srishti. All
Thank
the
you,
best.
sir.
All the best. You will do very well.
Thank you, sir. Thank you.
Thank you, Doctor.
Thank you, Srishti, for
Thank
your
you, sir.
presentation. Thank you, Kosam sir, Bala sir, for your valuable input, sir.
Thank you, sir.
And thanks to all the viewers and Juventus group for kind support. Thank you all.
Thank you.
Good night.
Good night.
Good night.